The next topic we'll be studying is intercostal water seal drain. Intercostal water seal drain, that is ICWSD, it is also known as chest tube drainage system. It is a closed drainage system used to remove air, blood, fluid, or pus from the pleural cavity while preventing air entry. It is commonly used in conditions using pleural space abnormalities such as pneumothorax, hemothorax, pleural effusion, and empyema. The water seal mechanism prevents air from flowing back into the pleural space, allowing lung re-expansion. So this is the main aim of the intercostal water seal drain. For that, we have to understand the anatomy as well as the physiology related to intercostal water seal drain. The pleural cavity is a potential space between the pleural parietal pleura that is lining the chest wall, here marked as a blue line in the diagram, and visceral pleura marked as a green line in the, which is covering the lungs. So that space in between, that is in between the green line and the blue line, is known as the pleural space. Under normal conditions, this space is a small amount of contains a small amount of pleural fluid that facilitates lung expansion during respiration. When abnormal air or fluid accumulates, it can compromise the lung function, leading to respiratory distress. Intercostal water seal drain helps to restore normal physiology by removing excess air or fluid and re-establishing negative interpleural pressure. What are the indications of intercostal water seal drains? It is basically to remove any fluid, blood, or pus or chyle from the pleural cavity. So, according to that, conditions are named as pneumothorax when air is in the pleural cavity, which may be spontaneous pneumothorax due to primary or secondary, traumatic pneumothorax due to blunt penetrating chest injuries, iatrogenic pneumothorax following central line insertion, lung biopsy, or mechanical ventilation. Sometimes tension pneumothorax develops as an emergency condition requiring immediate chest tube placement. Whenever there is blood in the pleural cavity, we call it hemothorax. It may be due to blunt trauma, penetrating chest trauma, etc. Rupture of aneurysm or vascular injury, post-operative bleeding following thoracic surgery may also cause hemothorax. When there is fluid accumulation in the pleural cavity, it is known as pleural effusion. It may be malignant, tuberculous, or cardiac failure associated pleural effusion. Whenever there is pus in the pleural space, it is known as the empyema. It may be complicated pneumonia, tuberculosis, empyema, post-surgical or post-traumatic empyema. Sometimes we place the intercostal water seal drain as a part of post-operative drainage, that is after thoracotomy, lobectomy, pneumonectomy, or sometimes post-cardiac surgery to drain the mediastinal fluid or blood. What are the contraindication of intercostal water seal drains? Essentially, in cases of severe coagulopathy, we should avoid inserting an intercostal water seal drain before controlling the coagulopathy because this will lead to high bleeding, which may be difficult to control. Sometimes there may be presence of diaphragmatic hernia or suspected congenital abnormalities which are not properly diagnosed. Also, in patients who are in urgent need of sternotomy, we should preferably do the sternotomy directly instead of putting a chest tube. What are the components of chest tube? Firstly, the chest tube, that is the intercostal drainage catheter, which is inserted into the pleural cavity. It is connected to a water seal chamber, which is a one-way valve, prevents air re-entry back into the pleural space. There is a collection chamber which collects the drainage fluid. There is a blood, pus, or serous fluids, etc. There is also a suction control chamber, which is present usually in 2 bottle, 3 bottles, and other systems, which regulates the negative pressures to facilitate drainage. Here is a diagram showing the whole of the intercostal water seal drain systems. Here is the lung, which is and the pleural cavity. So here we can see the intercostal water seal drain. Here is the connector, which is drainage. This is the drainage tube which drains into this water seal. This is the water seal. This is with uh, fluid with minimum of 2 to 3 centimeter immersed in this fluid, and this is the collection chamber where all the fluids are collected. This is particularly a 1 bottle system. Also, we can see a suction port in this tube in this system. Regarding the procedure for chest tube insertion and water seal drainage, sometimes we need to prepare the things as needed for chest tube insertion. Before that, we have to obtain a proper written consent, and we have to explain the procedure to the patient party. They should give a full written consent. Also, we need to confirm the indication by reviewing the investigations, also by doing clinical examinations. Also, we should give emphasis on the identification of the correct site based on the clinical and the radiological findings. Positioning of the patient. Patient is either positioned in the supine or semi-forward position, with arms raised over the head like shown in the image. So here we should learn about the triangle of safety. It is a space covered by anteriorly by the lateral edge of the pectoralis major muscle. This line shown in the diagram in which forms the anterior axillary fold. Posterior axillary fold forms the posterior boundary. This is the lateral edge of the latissimus dorsi muscle. Below is it is bounded by the fifth intercostal space and the fifth rib. Superiorly, the apex is formed by the axilla. So sterility should be strictly maintained during the procedure, and local anesthesia should be instilled in the site of insertion. Equipments required are the chest tube of varying sizes, particularly 24 to 36 French for fluids and 16 to 24 French for air. Scalpel, forceps, sutures, chest tube drainage systems are the other essential systems required for chest tube drainage. First, we have to mark the place. This is the place in the triangle of safety, and we have to mark a linear 2 to 3 centimeter incision site. In that site, we have to infiltrate local anesthesia. The direction and the position of the insertion of the syringe as well as the chest tube is the upper border of the lower rib of that particular intercostal space. We should avoid to go through the upper side because the neurovascular bundle is present in the lower part of the upper rib in that particular intercostal space. So after instilling the anesthesia, we have to give the incision, and with artery forceps, particularly Kelly's clamp, first we have to dissect to reach up to the parietal pleura. Then we have to clamp this. This is the intercostal water cell drain and the chest tube, which is clamped by a Kelly's clamp, and we have to give a thrust and advance through the incision into the pleural space. Then once it enters, we have to connect it to the intercostal water cell drainage system. Also, we have to fix this chest tube to the chest wall, and so we also put a purse string suture around this wound so that while removing the chest tube, we can tighten that suture and the opening is closed. So again, we are here. It is mentioned about the chest tube insertion incision site, which we have already discussed. The tube placement and securing is also given here. The direction of the tube is particularly important. That is upward for air and downward for fluids. We have already discussed about the suturing and occlusive dressings after application of the chest tube. Regarding the connection of water seal drainage system, the tube is connected to a sterile water seal chamber, which is shown in this diagram here, which ensuring one-way air fluid flow. So by the gravity, the fluid will come here, and also due to this downward placement of the intercostal water seal drainage system, there will be a negative pressure in the pleural space, which will suck the air also, and the air will be then cleared out to the atmosphere. And because of this drainage system, although there will be atmospheric pressure, but it won't be sufficient enough to push back the fluid back into the pleural cavity. So thus both air as well as the fluid is evacuated from the pleural cavity using this system. Regarding the monitoring and management of intercostal water cell drainage system, first we have to observe for bubbling and swinging movements. That is if there is air in the pleural cavity, obviously there will be bubbling of air bubbles, and it will be shown in this water column. There may be intermittent bubbling in normal pneumothorax indicating air removal. If continuous bubbling is present, this may indicate a air leak which is present due to a bronchopleural fistula. That is directly from the bronchopulmonary tree. The air is directly coming into the pleural space, and then it is going through this intercostal water cell drainage system. Regarding the swinging movement, which is the fluctuation of the fluid in the tube with respiration, that is with expiration and inspiration, the fluid level, that is the air fluid level column here will be going up and down accordingly. This indicates the proper functioning positioning of the tube. We have to also monitor the drainage and the output. Sudden cessation of the drainage in hemothorax may indicate a clot formation. Excessive output more than 200 ml per hour requires immediate review. Even patient may require thoracotomy for hemostasis. Assessment for complications like subcutaneous emphysema, that is the if the tube goes in between the layers of the thorax instead of going into the pleural cavity, there may be infection in the insertion site, or there may be associated infection in the other sites also, or dislodgement of the tube, including injuries to the adjacent structures present in the thoracic cavity. Regarding the removal of the chest tube, indication for chest tube removal includes the resolution of the pathology. That is the full lung will fully expand on chest X-ray. In cases of fluids present in the pleural space, the drainage volume should be less than 50 ml for 24 hours, more than 24 hours, and it should be serous drainage, not hemorrhagic. There should be absence of air leak, that is, there should not be any bubbling in the continuous bubbling or bubbling in the air water cell system. Also, the patient should be clinically improved and its vital signs should also be stable. The procedure of removal: first, there should be a clamp applied to the tube for a few hours. That is the trial of tube removal in some cases. We are in doubt. We should instruct the patient to perform forceful expression during the removal. Also, if possible, we should apply a mild negative suction while removal. Applying occlusive dressing immediately to prevent the air entry. Also, we can tighten the purse string suture which we have applied during the insertion of the chest tube. We have to monitor for the respiratory distress as well as we should clinically assess for any respiratory distress. What are the complications associated with intercostal water cell drainage? Firstly, the malposition of the tube, that is incorrect placement leading to inadequate drainage, or inadequate insertion of the chest tube into the pleural cavity. Also, there may be air leak or persistent pneumothorax due to tube dislodgement or lung injury, which may lead to bronchopleural fistula. That is the direct communication into the bronchial tree to the atmosphere via this intercostal water cell drainage system. Hemorrhage: there may be injury to the intercostal vessels or lung parenchyma, which may be lead to intractable hemorrhage. There may be infection like empyema, cellulitis of the insertion site. There may be subcutaneous emphysema, that is air leakage into the soft tissue planes of the chest wall. If the fluid is expansion of the chest, that is the lungs, which may further develop re-expansion pulmonary edema. So rapid expansion of the collapsed lung should be insertion of intercostal water cell drain improves survival in case of trauma patients and with respiratory distress patients. Also, it helps in resolution of the pathology of the pleural cavity. Early mobilization and physiotherapy also aids in preventing complications of the intercostal water cell drainage system. Proper monitoring ensures successful lung re-expansion and prevents the complications. So, some of the questions that may be asked while giving a short case. Like they may ask what is your case, then you have to give a brief summary with chief complaints in chronological order, any associated history, relevant past history, family history, like tuberculosis history, or any history of contact history, personal history of smoking and other associated habits, or any occupational history, or positive findings for examinations, or how you have to give the provisional diagnosis depending on the history. We should an examination we should try to find out the indication for chest tube insertion, and thus we have to give the provisional diagnosis as left or right sided intercostal water cell drain in situ, and if possible we should mention the indication for which the intercostal water cell drain was given, which is not compulsory. Then why was the intercostal water cell drain given? From the history, like is there any trauma history or any previous history of tuberculosis or any other smoking history? From that we have to conclude whether it is a case of any air in the pleural cavity or fluid or blood in the pleural cavity. According to that we have to come to a diagnosis, and we have to give the indication for insertion of the chest tube from the above mentioned list as we have discussed previously. What are the components of chest tube? As we have already discussed, the chest tube proper, then there is a connector, then there is a drainage tube, and there is a collection chamber, and there is a underwater seal, and this tube should be immersed 2 to 3 centimeter into the water, or water should be filled up to the initial mark or minimum level, and there is a suction port which provides negative intermittent negative suctions to clear out the pleural space. And regarding the size, what are the various sizes available for intercoastal water seal drainage system? It starts from 6 fans and may go up to 14 fans or higher, depending on the indications, as we have already discussed previously. What are the various type of intercoastal water seal drainage systems? It may be one bottle system, like we have discussed in most of the pictures. There may be two drainage systems. Here, the fluid comes here and collects. Then again, the suction is placed in a second system. Three bottle system. The benefit is that first is used for collection, so all the collections will be here, and there is no chance of reverting back into the pluvial space. And the second is the water seal proper, and third is the that suction tube, and here the middle tube is also open into the atmosphere. How much centimeter below the chest the intercostal water should be placed, and why? This is a very important question. Like, it should be placed minimum of 100 centimeter below the patient's bed level, that is at the point of insertion of the chest tube, so which leads to a creation of a negative suction pressure of more than 80 centimeter. And why this is important? Because this is the highest interpleural pressure. This is the negative pressure, so it may suck the fluid back into the pleural cavity. So if this is more than 100 centimeter and more than 80 centimeter of H2O, then there is no backflow of the fluid into the pleural cavity. So how much tube should be immersed? It is 2 to 3 centimeter, or fluid should be up to minimum mark, as already marked in the ready-made collection chamber. Why fluid should not be evacuated more than 1.5 liter per setting? Because if rapid evacuation of the fluid will lead to development of re-expansion pulmonary edema. What may be the reason if some column, if the water column is not moving? So first we have to think that the pathology for which we have did the intercostal water seal drainage, that may be resolved, or there may be blockage of the tube. Blockage may be due to kinking, cramping, opening of the chest tube is blocked by a blood clot in cases of hemothorax or hemorrhage from the intercostal arteries, or there may be a mucus plug or any pus debris which may clog the drainage system, or there may also be malposition or dislodgement of the tube from the pleural cavity. And lastly, we may be asked about where the three-chamber intercostal water cell drainage is most commonly seen. It is most commonly seen after cardiac surgery, and so these are the things which we have discussed in intercostal water cell drain. Hope we have you have learned the topic very well. And if you have any doubt, put it in the comment section, and we'll try to discuss it in the further lectures.